Hello, and thank you for joining us for today's virtual education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Choices at End of Life. Before we begin, if this is your first time joining us, CSC South Bay's mission is to uplift and strengthen people impacted by cancer by providing support, fostering compassionate communities, and breaking down barriers to care. Our vision is that everyone impacted by cancer receives the support they want and need throughout the experience. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join our community, please visit our website at cscsouthbay.org. Before I introduce today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. And if you have any questions, feel free to put it into the chat function, and Karen may answer it alongside a presentation, or she will answer it at the end. Without further ado, I'd like to introduce our workshop speaker. Karen Morin is a seasoned oncology and hospice nurse with extensive experience in MAID, medical aid in dying. She founded LA Patient Advocates, an RN-led patient advocacy practice that partners with hospices and referring physicians to guide patients and families through the complexities of serious illness and end-of-life decision-making. Thank you so much, Karen, for being here with us today.
Thank you. Thank you for inviting me. I'm glad that I can be here this evening. And I hope that I can answer a lot of your questions about this time and this time of our people's illnesses. I think it takes many different directions. Well, first, I just have to get my slides going forward. It doesn't know. I'm going to add something else to this slide. It's not just death that we don't talk about, but we don't talk about serious illness. I was in a room yesterday with a lot of people, and we knew that there are a number of people in that room that were seriously ill. And there's whispers and people talking about it, but it's both of these instances where the elephant is in the middle of the room, but people really aren't discussing it. And so we're trying to bring some of that out in the open, not only talking about death and dying, but talking about serious illness and what we do and don't want at the end of life. And if you ask people, they'll say, "Oh yeah, I know what I want, or I know what I wouldn't want." But most of them have not actually put this down on paper, and they haven't really explained what those wants and what those unwants, let's say. You may have an experience and you heard about an aunt that was in the hospital and they went through this, and then you're going to hear, "Oh boy, I would never do that." But have you written it down? Have you explained what are those things that you would want to have done? And where is your line? What is that quality of life that you're not willing to go any further on? And so we plan for births, we plan for weddings, we plan for college. We don't really plan and prepare for death and dying or even serious illness. And all of a sudden it happens and it's upon us. And whatever those discussions were that we had in our head, I'm going to talk a little bit about advanced directives, but this next month, right, we're going to do a hands-on workshop, really going through advanced directives and POTS and some of the paperwork. And when we're there, and you can actually go through step by step and understand what each of these decisions really involves, it's much easier. But we'll touch on a little bit, because advanced directives are that document you may have filled out a while ago, or maybe your doctor talked you into filling out now about what you would or wouldn't want if you weren't able to say what your wishes are. Most times they're going to come up to you in the hospital and say, "Look, here's what the options are right now," and you make a decision. But if you're unconscious and not able to make those decisions, supposedly they're going to look at your advanced directive, and they may turn to whoever was named in that document who is going to then make decisions for you. So we'll talk a little bit about how this works and doesn't work, but I just, to touch on it, it shouldn't be a one and done. It should be an ongoing process. Don't say, well, I filled that out 5 years ago. I want you to look at it each year, or if there's a change in your condition, visit it each year. And even if you go back and look at it, you can write on there, put the date down, sign it, and say, I've reviewed this, and I still wholeheartedly agree with everything that's on it. Update it and put your signature on it. These documents are meant to promote conversations with your family, because the reality is, when it comes time to making a decision, when you're not able to make it, it's going to be family members talking to the doctor and make a decision. 9 times out of 10, they're not going back to that document and said, oh, let's see what Aunt Susie filled out a few years ago. They're going to talk to your family members. So if you haven't talked to your family about what's really important, then they're going to be choosing what they would want for you and not necessarily what you've decided that you want. So look at these forms every year. We're going to look at them next month together. If you have one of the 5 Ds, it's been a decade, you've had a death, a divorce, a change in diagnosis, or a decline in your health condition, you should look at it again. And if you don't want to change anything, you can also add addendums to your document. One of them is the dementia addendum. These are all these great eggs I'm dropping. So you'll come next month and go, oh, I want to figure out about that dementia addendum. What does that mean? Okay, so the other part of this is getting into this ongoing conversation with your doctor. Make sure that you have consultation and collaboration, that he or she knows what you want and don't want. And you can have an end-of-life discussion at any time. Medicare pays for an end-of-life discussion appointment with your doctor to go over your advance directive or talk about what you want or you don't want. It's really important, especially if you have internal medicine or a specialist you're working with. It may not be one conversation. You may need a couple of conversations, especially if things have changed. Ask your doctor those hard questions. And, I would suggest having somebody with you for those, because those kind of conversations, you tend to forget half of what gets said. But what if I do nothing? Or what if I don't want to have treatment? What if I'm done with treatment? Or what if I want to try this new trial? What can you see some of the possibilities? What can I expect in the next 6 months? And find out what this word treatable means, because treatable is not the same as cured. So how will that change your quality of life? Look for those words and understand what they really mean for you. They may not mean the same as someone else in one of your support groups. And also discuss with doctors if you've got milestones coming up. Do you have a big wedding or bat mitzvah or something that you want to be well enough to attend? Make sure they know about that. So this will be my last thing about advanced care planning until next we meet. But a couple of the myths. The loved ones will know what I want when it comes. Well, not really if you don't tell them, if you don't talk about it. And a lot of people end up guessing wrong. So don't be dropping miniature clues. Have a heart-to-heart discussion. You need a lawyer to create an advanced care plan. No, you can download them from the internet, or you can pick one up that I'm going to bring next month. And they're free, and you can change them at any time. You don't, the idea that only if you're sick or very old do you need one. No, I have a couple of patients right now that are in their 50s and 60s. Young people get ill too, and emergencies happen. And only works if it's in writing. That's also not true, because the most important part is discussing what you want so your loved ones know. Again, those are going to be those discussions out in the hallway with the doctors that we see on TV all the time. They're asking what you think that your loved one wants. And indeed, you can change them at any time. So questions to ask your doctors, what is, and yourself actually, what's your understanding of your health condition now? And think about some of your friends or family who faced serious illness. What has it been like for them? What have you seen that with their care that you would or wouldn't not want? And look at your quality of life, the activities that you enjoy most. I heard someone the other day say, well, as long as I can get to the Dodgers, or as long as I can play around the golf, or as long as I can be there with my grandchildren. So figure out what living well means to you. And think about, if your condition does change and it worsens, what are you willing to trade off? What is most important to you? And even if you're just thinking some of these things through, it will help when you have that discussion with your physician. I think the more we do this, the more we think about it, the more we talk about it, the more likely you are to have your wishes honored and get a better understanding of what is going to help to make your life full of quality and meaning. And it gives your family that sense of, they know when the time comes and they have to make decisions, that they truly are doing what you want. Make sure you're not using this language that doesn't mean anything to everyone. No heroic measures. I don't want to be a vegetable. You got to be specific. And living well to some people is very different from someone else. So be specific and clear. Someone once said, oh, we did all this paperwork, and oh, I heard about this lady. She had everything. She got to the hospital and no one paid attention to any of it. And, that happens. But so what can you do to help to ensure that your wishes will be followed? Make sure you have a healthcare proxy that is going to stand up for you. You want someone who is going to be the kind of person that speaks up, that isn't going to meekly go along with whatever the doctor. So it may not be your closest relative. It may be that loud, get in your face neighbor who's a good friend of yours. It's okay. They don't have to be necessarily related to you. Communicate your preferences and share documents with them and keep them updated. And educate your family and friends, those that you expect to be there at the end, exactly what your priorities are, and state it. And lastly, make a video, a little video on your phone or an audio recording. It really helps to reinforce those positions you've said all along. Hey, mom made this video. I know that she truly believes in this. And it does give comfort to loved ones to know that they really are following along with what your wishes are. Oh, I really have gone on a while about what I'm going to talk about next one. But I think make a copy for the hospital and a copy for your doctors. And all right, let's move on here. But again, it's not just the paper that is important, it's people. It's making sure that people know what you want, and they're the ones that are going to step up for you when and if you need it. Okay. I'm going to talk a quick second about what we see on TV, because I know you're all watching some of those medical programs. And, oh, sorry, I'm jumping all around here. Sorry, my mouse is very... So, everybody gets shocked during CPR and they all wake up, or they're intubated, and, before the show's over, the tube is out and they're talking and they're all fine. And we all know that doesn't really happen in real life. It's really only about 18%. It depends on which study you read and whether it has to do with people that are younger or what condition their heart is. So I want to talk about having, as we fill out these documents, a realistic explanation, expectation of what would happen and what it would be like if we were resuscitated afterwards. So that the chances of actually having CPR by a bystander and recovering and walking away and have full senses of your mind are very, very low, unless you're younger. If you're in your 50s or younger. I just had a nephew who was an ER doc. He had a heart attack at 30 and just recently had a major heart attack, and he really was and had defibrillation. This guy is going to be fine, but the older we get, the much higher those numbers are, whether you would survive CPR and defibrillation. So it's interesting to know some of these statistics and to understand your body, the condition of your heart and things. And these are good questions to talk with your doctor as you're choosing on some of these forms, which we're going to talk about next month, about whether to choose CPR or not. This form we'll go over later on. But there's another form we're going to talk about, the pulse, which is the one form anyone who has a chronic condition should get filled out. It's bright pink, hence the bright pink font. It's pulse physician's orders for life-sustaining treatment, or the medical one. That's the New York version. There's all different letters, but in California, it's pink and it's called the pulse. And one of the reasons it's so effective is it's signed by a doctor. So when you get to the ER and you can have all the documents you want, but everyone's going to pay attention to the pulse. If you have it in your home and you have an event and they call the ambulance is going to look for the pink form and they're going to pay attention to it. So we'll go into a little bit more, but I want you to be aware of it between now and the next month or so. If you are someone with a advanced disease or terminal, or you want to make sure that no one's taken you to the hospital, the pulse is a good thing to have. We're also going to talk about dementia directives and tools, so that people always say, we have all these advanced directives, but what if I get dementia? And this is a good tool that if you start to have signs of dementia or Alzheimer's, you can be very specific about what you want and don't want. And so I'll bring that with me next month. So it helps to talk about each stage and what you would want and wouldn't want. Discuss the options early, and I would we'll sign it and staple it to your advanced directive. And you can even write like a personal statement. This is what I believe about it. And like I say, sign it and date it so people know that you've reviewed these and you still feel the way you do. So let's talk about these end-of-life options. The first one is pursuing all life-sustaining treatment. And let's understand what that is. That could be CPR, a breathing tube, or a ventilator if you were to need that. Feeding tubes or IV nutrition, right? So if you can't eat or swallow, how are you going to get nutrition? One is going to be an IV, which is really a very short term, probably only a few weeks will they do IV nutrition. And then either you have to have a feeding tube implanted. So dialysis, if you have kidney failure, there would be medications that would help maintain your blood pressure if it's too high or too low. And then ICU care. Those are all life-sustaining treatments. So the other option is discontinuing or declining certain medical treatment. And we all have the right to decline any medical treatment at any time. So it's your body, it's your choice at any time. So again, we will always support any patient who says, I don't want to do this, or I don't want to do this anymore, or this is the part that I'm not. It even applies to someone who's refusing treatment, and it means that they may die. Anyone, any adult has the right to refuse medical treatment at any time for any reason, including those that are hospitalized, even if you're in emergency care, If you're in a facility, even when living in a nursing home or assisted living, people are getting home care. I recently had a patient who decided that, well, I'll talk about that in a little bit, but yes, any place, anywhere. So you do always have that right. And it was interesting. The patient I'm thinking right now that I'll tell you about in a minute was a nurse. So she knew what she could. But when you decide that you don't want treatment, it doesn't mean that everything has to stop. Pain and symptom management continues. You can say, I don't want antibiotics, or I don't want chemotherapy, or I don't want dialysis, but that doesn't mean that pain management or other comfort treatment doesn't continue. Right? You always have that right to dignity and quality of life. But and you don't need a specific reason. Adults have the right to make this decision independently, and healthcare providers are obligated to respect that choice. So I don't mean to be reading right off there, but I want to make sure that I've made myself very clear. And all care facilities, no matter where you are, must honor this right. So you may have to work with the staff, especially some of the nursing homes or assisted living. You know, they're invested in that everybody doing well, and especially in some of them, you know, have you eaten? So if patients are not eating, or why are you not eating, those kind of things. But we can help support you. But yes, you have that right. But it doesn't mean that you have to suffer. Pain medication to control anti-nausea, anxiety, and psychological support, social workers, spiritual advice, and all these systems you need with activities of daily living, bathing, clean sheets, all those things. So if you're living in a care facility, put it in writing what your wishes are. Talk to the team and have a direct conversation about what your wishes are, so everybody knows. If you need a patient advocate, we can help find you one. But and there certainly are plenty of written facilities are legally required to respect your wishes. They can't send you off to something else. So, and these are some of the documents we can go over next month too. But all of them are good for a specific issue, and together they work together. But we'll go over them. So just remember, your body, your choice, your right. Every adult has the right to refuse treatment, but it doesn't mean that you don't get care and the care that you need. So a little bit about palliative care, because we hear that word a lot. It wasn't around a lot, but it is. It's a specialized medical care, especially for people with serious illness or often many illnesses. So there's a point in our treatment where, look, we're not going to make this a whole lot better, but we can do better to manage the symptoms that are there and that you're experiencing. So when someone is suggesting a palliative care consult, it's not like they think they're going to be able to make everything better, but we're going to make your quality of life better. These doctors and clinicians are focused on managing the symptoms in the best way possible. Especially we get to a certain point, we all have, you know, this long list of what's the patient's diagnosis, and they'll have, you know, 10 or 20 things there. So everybody's giving you meds. You want somebody to look at that and say, hey, we can get rid of this, we can get rid of that. Let's make sure that this patient is taking what they really need and what's really going to make the best possible difference for you. And again, with that quality of life issue. So pain management, please, please, please. And I know people have to hear this over and over and over again, but everybody should be ensured that they're giving good pain management. I know I've heard all the excuses. Oh, I don't want to get constipated. Oh, I don't want to be flaky. But you should have access to appropriate pain managed specialists. And whatever side effects you're unsure about, afraid of, or don't want to deal with, there is a way to deal with it that can make sure that you're comfortable. people who have their pain well managed are going to have a better quality of life. So consider how much pain you might be able to endure in exchange for other quality of life. But we should be able to ease your pain as a priority and make sure that we maintain that quality by taking a certain amount of pain medicine every few hours. If you take pain medicine and then the pain goes away and then you don't take anything else, well, now the pain's gone back down. And if you wait till it gets down at the bottom again and it's starting to get really bad before you take the next dose, well, now you got to get back to that point again. So it's really important to get on a pain management regimen where you're going to take it just as it starts to wear off. And if you're having side effects in the beginning, I promise you, most of those side effects will go away as you take pain medicine and you're getting used to it a little bit. And if you're having side effects, let somebody know, because there's laxatives, there's Miralax, there's anti-nausea. And then it might not be the right one for you, but let us know what you're experiencing. And yes, take it around the clock. So hospice. I might get into hospice early and often. It's not just for dying. Hospice can provide a level of care that we can't provide in many other places. You don't, too often people get on hospice and they'll die within a few weeks, but you can be on hospice 6 months, even more. At the end of 6 months, we look at the patient. If they've continued to decline, where their condition has continued to worsen, then you can up them for another 6 months. But a patient who's on hospice being in your home, hospice is coming to visit you at home, and all the medication that you need for comfort care is sent to your home, and anything else you need. So you can stop at any point. If you're on hospice and you say, you know, I just heard about this trial, I think I want to go back and get treatment, cancel hospice and go back and get treatment. You can keep your doctor. You can be on hospice if you're walking and talking. You can be on hospice if you're going to play canasta every week. It doesn't, there's a lot of factors here. It doesn't truly matter, but it doesn't provide, it doesn't provide enough medical care. Yeah, it provides care about your primary diagnosis and symptom management and pain management, but it provides a lot, and it's definitely worth looking into and talking to. You can get a hospice evaluation and talk to someone, at least understand what it would mean for your care and when. The big point is don't wait. You have to be 6 months or less expected life, but like I say, that varies. Most patients end up living longer and they just get re-up. It involves comfort management, comfort care. They're not trying to cure you of anything, but they're keeping you comfortable and as active as they can. And like I say, not all patients are actively dying. As a hospice nurse, I had many patients that were up and about. We'd meet with them once a week and we'd watch to see how they started to decline. Weekly RN visits, you could have aides that come and help with bathing and changing beds and all. And not all hospices are the same. So be sure to ask about what services they provide. And you can go off at any time if you're not happy. Okay. Mostly what I've already said. So, but good support, and they do have an interdisciplinary team. So this just talks a little bit, people get confused. What's the difference between palliative care and hospice care? So together, they're offering you a higher quality of life, helping you cope in comfort care. But palliative care is any stage of disease, where hospice is the last 6 months and transitioning is palliative care. One is a supplement and one is really more for quality of life at end of life. And hospice is usually paid by Medicare and insurance too, if you're too young for Medicare. And anybody have any questions? I don't think I have my chat turned on, so you may have to wave or unmute or something. Just don't, your doctor will say, oh, I'll refer you to hospice. Here is the name. But you don't have to go with the hospice the doctor is recommending. And if you're looking ahead of time and you want to interview, go ahead and interview them. There's a lot of them. I know there's been a lot of issues lately about some bad ones and frauds, and it didn't take much to get a hospice license. So maybe that is one way to talk to your doctor about which ones. But and I can give you some names of some good ones, but talk to them. How long have they been certified? The benefit is that hospice should have somebody available 24/7 for you that you can call with any questions. And some of them have other benefits. They bring social workers, some have dog therapy, find out what else they provide other than what Medicare is requiring it. And do they have a policy regarding medical aid in dying? And if it is, or whether they prescribe it or whether someone else comes in and does medical aid in dying. Ask about other options. So speaking of medical aid in dying, so we're going to go over a couple of the end of life options, but medical aid in dying has been legal in California since 2016. It is a trusted practice for someone who has been diagnosed with 6 months or less. They can request a prescription that they can use at some point to self-ingest so that they could die peacefully without any suffering, with dignity. I guess that's it. That's how they got the other name, death with dignity. It's actually, this is a summary of, people always ask about Europe and is it an IV or is it, so the United States is not 11 states, there's 13 states, Canada, but some of the other countries use IVs or the oral. In the United States, it's only oral. And it's only the Netherlands and that will allow for dementia. People, that's always the question. What if you have dementia? Can you use medical aid in dying? It has a high level of support, though a lot of Californians don't even realize that it's legal here. Over 75% supported it when we were getting it passed. So just a little more about medical aid in dying. Now, this is the newest as of 2026. So there are 3 new states that just passed it: Illinois, New York, and I think Delaware was the other new one. I just talked to someone today who's in Florida and is moving to California to use the law. California, it says you have to be a resident of California, but there's nothing that defines what a resident is or how long you have to be here. So generally we tell people, you move to California, you either register to vote or get a driver's license or have a lease that shows that you're here. So 18 years or older, terminal, again, with 6 months or less. Again, we don't know. People live a lot longer than 6 months, but it has to be a terminal diagnosis. The 99% of these patients are already on hospice, and we encourage them to be on hospice to get, so have that pain management and have the round-the-clock quality of life comfort care that we want. And the ability to self-ingest. So self-ingest means that I can mix up the medication, but you have to be able to drink it independently. I can hold the glass, but you have to be able to put the straw in and drink it. And we also, because we have to use the GI system, we can also do it rectally, which I think we talk about in a minute. So it requires 2 verbal requests to one doctor, the prescribing doctor, wait 48 hours, and then you do another request by a consultant doctor. So there's 2 doctors, and then there's 1 form you have to fill out. This is the only picture I can find that showed self-ingest. I don't know what other picture they've had here before. So you can use, when we talk about rectal, we actually do like a rectal catheter, attach a big 60 cc syringe that then the patient has to push down on, so that big bolus of medication will go into the rectum like a big suppository and get absorbed that way. And that's important because if you think of some of the ALS patients or brain tumor patients, so that they've got to have that strength in their hands so they can make it happen. The death certificate will always say the underlying disease. Was it a heart disease? Was it a brain tumor? There's no mention anywhere of a patient having used medical aid and dying. So no one will know unless you want to tell them. But I know that people are talking about it because I know our numbers have gone up every year. They double. So people are finding out about it and are using it more. So you can't say I'm 98 or this patient's disabled. It has to be a terminal disease. And again, like wills, insurance, none of that is affected. Again, the death certificate is going to say, cardiac disease. There's no mention of MAID. It's not suicide, okay? These are people that are all actively dying. They have a terminal disease and they're dying. It's no matter what you read in the media, it's medical aid in dying. It's aid in dying, assistance in dying for people. It is not suicide. They would die on their own if they didn't take the medication. So in practice, we give them two medications, Reglan and Zofran, about an hour before to prevent nausea. And then we mix up the medication. It's really 5 different drugs that come as a powder. We add some liquid and mix it up, and then they drink that medication. And within about 5 minutes, the patient falls asleep. And within I usually say about 2 hours, the patient cardiac and respiratory activity will stop. It's a very, very peaceful way to go. These are the drugs: digoxin, diazepam, which is Valium, morphine, amitriptyline, phenobarbital. And what else can I tell you about that? So the patient must hold it. We can mix it and hand it, but we do hold it. So really the act of drinking it out of the straw themselves. Sorry, there's a noisy dog over there. So 4 to 10 minutes is the average, and 2 to 5. The medication is pretty bitter. Sometimes there'll be a little bit of burning. Usually we'll do some sorbet, some fruit sorbet before and after to help with that. So I don't know why so the time to death can be a little longer. I think some of these slides are from one of the hospice presentations. So as you can imagine, you drink the medication and then it's absorbed. Some of the drugs are absorbed right away. That's why the patient falls asleep right away. That's why the combination has been chosen the way it has, so that patients will fall asleep right away. The rest of the drugs are absorbed lower down into the bowel, and that's why you see that broad range of numbers as to how soon some patients are going to die. And it really depends on the extent of the disease in the lower abdomen. If you have some GI disease, if your bowels haven't moved very much, if you haven't been eating a lot, those receptors in the bowel are not going to be very good at uptake of the medication. So that may take a little bit, which is why we tell people to keep eating even a little bit each day. So if we're doing rectal, they're going to have to push down on that syringe. We may do a little prep the night before, and we usually say it's good to keep doing some clear liquids the night before. So for some people, when we talk about pain management and trying to get people comfortable, some people just knowing that they have this prescription for the aid in dying drug, it's really helpful to think, oh, it's nearby. If things get really bad or if the pain medication isn't working, I've got the aid in dying drug here. And well, it's not going to be here. We keep it in our safe, but we're nearby. Someone says, okay, I'm ready. I want it tomorrow. We'll be there the next day. We don't leave it in the patient's home. So here's what, have a conversation, keep having conversations, complete the advanced directive and update it. If you're diagnosed with an advanced illness, make a post form and update that as you need it. And, we're all crossing our fingers that your wishes will be followed. Some of the issues we've run into, if you're a resident in assisted living or a board and care, sometimes we can run into bumps, but you have the right as a California resident to use medical aid in dying no matter where you are. So if you start to have issues somewhere, let someone know and we can make sure that we're advocating for you. But nobody has a right in any facility to tell someone they can't do it. It's just not legal. It's also, if you're already on hospice, it's really a matter of drinking something. And a lot of facilities don't even have to know it's happening. I mean, it's nice to share this information, but again, there's such a thing called HIPAA. You have a right to privacy. Again, your death certificate is going to say whatever you're underlying. So if you choose not to inform people, you do have that right also. Sometimes they haven't told everybody in their family. I've had patients with a number of children and a couple of the children knew and others didn't know. And, it's that difficulty thing sometimes. How will I know what day or how will I know when to take it? And I always tell people, you will know. It's your life, your quality of life. When you're ready, you're ready. And sometimes there's a little influence from family one way or the other, but it should be your timing, and we're very sure about that. And I always say I can be very annoying because I'll always say, are you sure we can cancel? We can come back another day. Are you sure today is the day? Very rarely has that ever been changed. What I mean by if a patient can't change hospices, if you're on Medicare, you can change hospice whatever you want, okay? But if you're under 65 and not on Medicare, your insurance may only cover certain hospices. If you're on a hospice that doesn't provide medical aid in dying, you can do that outside of the hospice. And that's when you could call someone like me. There's a number of people in LA who facilitate medical aid in dying. Some hospices do it as part of their services. Some of them, there are like 20 hospices that call us to facilitate the process. So there's a number of ways that that can be approached. We find that more people are asking about it because of all of those things that you can imagine, the loss of autonomy, fear of pain and not wanting to have pain and suffering. And often it's just a matter of quality of life. But it's really not, we want to really emphasize, it's not about, it's about maintaining the quality of life that is the best for you. And only you can decide what it is that you want and don't want. And I put this in, this is kind of for hospice, but I get this a lot from families even. When patients are saying, oh, will you help me? Or I really want death with dignity, or I really just want to be able to go. I want to be able to go. And whether it's the hospice saying, oh, the patient's been asking for this, or the family member calls you up and says, yeah, he's asked 3 times for this. And my question always is, how many times do they have to ask? It's, when someone in your family is asking, go ahead and start the process. Starting the process just makes the family member know that A, they've been heard. We heard you, Dad. We know what you want. Let me make a call. Let's look into it and let's see what's involved. Let's see if you're even eligible. and let us go through those steps and explore that with them and find out what it is, understand what their concerns are. A lot of times the first thing I do is find out about pain and what that issue is, make sure that the pain and the other symptoms are being well managed, that they're not choosing medical aid and dying because all these other issues aren't being well addressed. Okay. And comfort and respect, that's what I really like to say, is that's the most important thing, is listening when people are asking and making sure that we're paying attention to what's most important for them. So let me open it up to questions. You can, if you want to put it in the chat or just unmute and ask.
Absolutely. Thank you so much, Karen, for reviewing all that great
I was
information.
trying to slide through the advanced directive and the paperwork part, but I know we'll end up talking about both next time. Excuse me while I catch this
Yeah.
drop off.
So this workshop is being recorded. Just an FYI. So if you want to put into the chat, feel free to do so, and I can read it out to Karen. And if you're okay with your voice being recorded, you can also unmute yourself as well. There'll also be time at the end where I will stop the recording, and then you can ask your questions live if you prefer that too. So the first question is, the California End of Life Option Act looks pretty straightforward. Are there any catches or hidden obstacles?
Think there's any hidden obstacles. I think as long as you have what we term as a terminal, like I say, 6 months or less. That's why I often tell people who call and they're not on hospice, I said there's no downside to being evaluated by hospice, because it's not required to be on hospice, but it sort of tells our doctors that, oh, they've been evaluated by someone else, they've been deemed to be 6 months. But there are a lot of times I think patients are reluctant to go on hospice and get that eval because you're not there yet. But I think it doesn't do any harm to not do that eval and talk to them. Find out, okay, what will it look like when I am ready for hospice? And because, like I say, many times people want to know what they need to do to have the option available for them. Exactly. Yeah. But no, I
Thank
don't
you.
think there's any hidden obstacles. I think the other thing to remember is not doing it the other way. You don't want to wait too long. Say someone with Parkinson's, let's say, because Parkinson's isn't necessarily terminal until, and I say once a Parkinson's patient isn't able to start to have difficulty swallowing, then they become in that 6 months or less terminal. But because we have to be able to swallow the medication, and it may be the same thing for someone with an esophageal tumor, we want to make sure that you're able to swallow. So when I talk about that 2 ounces of a thickened solution, don't wait so long that you get yourself into this situation where, oh, I'm not sure about being able to swallow, but again, we have the rectal route. So being aware of what and how that you'll have to take the medication is important.
Thank you. Next question. Which are the best local hospice organizations that accept and support end-of-life choice?
Oh boy. I mean, there are quite a few. I think there's most all of them. If you go on a hospice, I mean, if you know you want medical aid and dying, when you're interviewing hospices, you can ask them, but all of them will say, oh yeah, we support it. They're going to tell you that. But if they don't have a medical director, and that may be the most direct question, do you have a medical director that will prescribe for medical aid and dying? And I know there are quite a few don't, because they're the ones that call me up and say, oh, we have a patient that wants medical aid and dying. Can you facilitate it? But there are a few of them that have medical directors that will prescribe. and it's part of what they do. I think it's TLC and Olympia. And again, I would say call a few and compare. I had one the other day that was like, they were willing to have, the patient wanted to go on this hospice, but they wanted medical aid and dying. And the hospice was willing to pay part of my fee so the patient could go on. So if someone says, no, we don't do it, but we have someone will, be sure you ask, because some of them, even if they do medical aid and dying, they may have you pay for the medication. So find out what the fees would be with the hospice. And, when I do the other talk in advanced directive, I think I have a printout of questions to ask hospice and what to ask when you interview.
So I get for if you're looking for a hospice, um, how do you get started? Do you Google it? How do you find this list of
Oh,
hospices to kind of even ask around?
yeah, it is hard, especially now with this whole thing of fraud out there. And I'll do it sometimes because I'll put in a hospice name onto Google because I want to find their phone number really quick. And then all these other ones pop up. It's like, that game where you put in this one, but they really give you another one. So I think, first of all, I would ask your doctor if your doctor is recommending you talk to a hospice, or even if you're not ready for a hospice, tell your doctor that you want to be prepared and you want to interview a few hospices. And they will have someone come out and talk to you and explain what they do, how they might be different from other hospices, and then choose. But get your doctor's recommendation on a few. A lot of times they work with specific hospices, but doesn't matter. Your doctor, you can choose any hospice you want. So if you interview that hospice and you're not happy, just switch. It doesn't, your doctor is going to work with whoever you're with. And you can change at any time. You call up and say you want to switch. Because there really are a lot of advantages to being on a hospice with, they're going to send the medication to your house, they're going to provide nursing visits and really help to control the cost quite a bit and make sure that you're getting the care you need right up through. But for a while in California, anybody could start a hospice. You didn't have to have a medical license. So there was a lot of fraud happening. So yes, you can Google it, but it will tell you what the license is, and you can look them up. But again, the big ones have been around for a long time. Assisted hospice, Vitas, I can give you Gentiva. There's quite a few of the really big ones that have been here for a while. I can give you a list of the ones that also that I work with.
Thank you, Karen. KH's iPhone, if you're okay with your voice being recorded, feel free to ask. If not, we can ask later after recording has stopped. Okay. Next question. Do you meet with individuals to help organize documents for end of life?
Sure, yes, we do that. And I also have a couple of patient advocates I work with that will also work with patients. So we do have a whole team here to go through it, look at your documents. And like, what I'll do next month, sometimes when you look at the post of the other documents, you don't understand what some of these procedures are or what it means. What does it mean to be intubated, and what happens, and are you going to be able to get off of it, those kind of things. So and like I say, I think with this dementia directive, it's also very important to have. So yes, we're happy to go through paperwork with you like that.
Thank you. Next question. Regarding costs, does Medicare and or supplemental insurance companies like Blue Shield typically cover the cost of MAID? If a patient is on a legitimate hospice program, why or in what instances would the patient pay for the MAID care or meds, etc.?
Because medical aid and dying is not a federally approved program. Remember, only 13 states have medical aid and dying. and the federal government considers it, I'm not even going to say the word out loud, so they don't cover it. So it's like if your insurance company also wouldn't cover it. So it's an out-of-pocket expense. If you're with a hospice that will also do medical aid and dying, they'll take care of you. They'll do all that, but they won't pay for the medication. So let me know. Oh, I don't know why I went to that. Sorry. Let me know if you're in one of those hospices, because we have the cheapest pharmacy. They're only charging like $415 an hour for it. So, but if you run into that, give us a call and let us know. We can tell you the best way to get it. And we work on a sliding scale. So we're anybody who wants medical aid and dying, we're gonna make sure they get it with what they can pay. And the other sad thing, even though it's a California law and Medi-Cal should cover it, we have not found any pharmacy willing to take Medi-Cal for end-of-life option medication. So, we've got to find a way to pay for the meds, which is why I'm always looking for the cheapest pharmacy for the meds.
So how come you have one?
Pardon?
What, with all due respect, if I'm understanding you correctly, you're saying if it isn't covered by the federal government, and even though there's a state of California law that allows MAID, and that they will not cover the cost of the meds, etc., how is it then, with all due respect, that you're able to access these meds?
Well, we can access, the doctors will write the prescriptions. So it's a medical aid and dying is legal in the state of California and 12 other states. So there is a law that says that it's legal and you have to meet those criteria. But just because it's legal, there's states where abortion is legal, but insurance is not going to pay for it. Those are fees that are paid outside. So if I'm facilitating medical aid and dying, I've got to pay for 2 doctors to do telemedicine calls, and then we pay for the meds. And those are the costs that we incur to make sure that patients get what they want, if that's indeed what they want at end of life. I can go on for quite a while on the state of healthcare in this country and why we don't have a nationalized healthcare. We should have Medicare for all, and it should cover all these things. And
Thank you, Karen.
yeah.
Oh, sorry, go ahead.
No, I said
Okay.
just like it's legal in California, but getting a pharmacy that would accept Medi-Cal, we have not been able to find it anywhere.
Thank you, Karen. We're getting too close to 6 o'clock. We have a couple more questions. Are there inpatient hospice facilities in the area?
There's one called Sarah House. There used to be quite a few during the AIDS epidemic, but that's the only one I'm aware of now. I always said if I won the lottery, I would open one, but no, that's the only one I'm aware of. There are some boarding care facilities that will have a hospice bed. That's the best, like home-like environment if you need something like that.
Thank you. Does palliative care facilities also facilitate MAID?
Most of them will, yes. And like I say, they can't, if you're in a facility, assisted living, any of those kinds of facilities that are taking California money, they cannot tell you that you can't do that here. They can't say, oh, we have a policy. Well, that policy is illegal. We've found a way to work through it. And I had somebody at a board of care the other day says, oh, we really don't believe in it, but we know we can't stop you. And, it's very discreet. You're on hospice, you're in a room. It's not like a lot of people know what's happening at that moment. But we're very good about advocating for our patients and also, working with the facilities so they understand, what what the rules are and what the rights are and how they can document it.
Thank you. Before I talk about the next workshop with Karen, we have one last question. Do telemedicine appointments work for getting a prescription for MAID?
Yes, we do all of our, I, as the RN, go to the patient's home and are there with them. I do the education and explain and make sure they understand all the ins and outs and that they can cancel at any time. And then I facilitate the telemedicine. Every once in a while, we have patients that can do it on their own, or I have a doula that might go there. But yes, we're doing telemedicine for those visits. And we're
Wonderful.
still, yes.
Yes. Thank you so much, Karen, for your time and also for coming back here on Wednesday, May 13th from 12:30 to 2:30. This is a hybrid workshop, meaning you can join us online like today, or you can join us also in person and meet Karen in person, and she'll bring some forms with her, and she's going to be talking about advanced directives, more pulsed and dementia directives. And this is the in-depth step-by-step explanation of each of these documents. So if you're interested, please go to our website calendar at cscsouthbay.org to register for either in person or online. And again, thank you, Karen, so much for this wonderful presentation.
Glad to get to talk